Welcome back to the Tracheostomy Care Bite-Sized Series, Part 2. This session we're looking at suction, weaning and communication. My name's Andrew Foster and this presentation is an abridged version of the Critical Care Outreach Team's excellent tracheostomy workshop. So as you heard, we're going to look at suction, dressing the stoma and changing of tapes and tube security as well as associated documentation. We'll also discuss communication and psychosocial needs as well as the weaning process to taking the tube out itself. So recall that mucus produced in the trachea and bronchi are transported up to the larynx or the voice box by ciliated mucosa of the larger airways. The tracheostomy disturbs this by the loss of normal humidification mechanisms and a loss of a normal cough. So it's necessary to suction it out or aspirate it out. And you can see here this is done by passing a narrow tube into the tracheostomy tube itself and applying gentle pressure to suction it out. So how do we know when somebody with a tracheostomy tube might need suctioning? Well, there might be a decrease in the oxygen saturations from the baseline. The person might be exhibiting signs of respiratory distress, so looking anxious, shallow breathing, increased work of breathing, and a raised respiratory rate. Of course, you might hear some coarse lung sounds with or without a stethoscope. And the patient may be unable to expectorate their own secretion. So if you know the patient well enough, you'll know how able they are to do this. And as they get stronger, they can expectorate to the opening of the tracheostomy as their cough gets stronger, but they can't quite get it all out. You might need to send a sputum sample for culture and sensitivity. Or you suspect somebody might have aspirated their gastric contents after they've vomited. And this is particularly relevant if they have an uncuffed tube or the cuff has been deflated. Now, it's not a routine procedure. It's an as required or as necessary procedure, but you must assess every 2 hours as a minimum. Now, the suction technique itself can feel a bit fiddly to begin with, but once you practice it often enough, it becomes second nature. So first of all, you need to explain what you're doing to the patient, get their consent to do it, position them as they're most comfortable, although this depends on the severity of their illness, and provide some privacy and dignity. Patients have described that they feel embarrassed when other patients can see all of this muck being taken from their chest. Make sure you've got the appropriate size suction catheter, and they come in all sorts of sizes, and the equation is simple. You just take the tube size, and in this example it's a size 8, and you multiply that by 2 to get 16 and always subtract 2 to get the number, which is 14. So 14 French size catheter, that explains the internal diameter of the tube. That would be the largest that you could use for a size 8, although you can use a size 12 or 10, but they may not be as effective as a 14. Make sure there's a non-fenestrated inner cannula inside the tube itself. So this is to allow guidance of the suction catheter down to the end of the tube itself. The suction pressure is set at quite low, so depending on what suction gauge you've got, that's use 80 to 150 millimeters of mercury or 10 to 20 kilopascals when you've occluded the suction. This is quite important because suction can cause trauma if you apply it on the wall of the trachea. Both measurements measure the same vacuum. And beforehand, make sure you wash your hands and use your personal protective equipment, which in a non-COVID patient is gloves and apron and goggles to protect your eyes. But in these days of COVID-19, that means that you must wear a full-length gown and gloves with a visor or goggles and an FFP3 mask, provided you've been fitted, because in COVID positive or strongly suspected COVID positive patients, this is what we know as an aerosol generating procedure. So once we're ready to suction, we pass the catheter into the tracheostomy tube without applying suction. And once we meet resistance or a cough, then we withdraw the suction catheter by 1 centimetre. And this is to make sure that we're not applying suction to the wall of the trachea itself. Close the suction hole on the catheter with your thumb and withdraw it slowly over up to 10 seconds. If it's any more than 10 seconds, the person's at risk of becoming hypoxic, because remember that we're not just suctioning secretions, we're also suctioning gases such as nitrogen and oxygen. After the suction tube's been removed, discard the tubing inside your sterile glove and assess the patient and repeat if you need to with a new suction catheter. You want to note the amount of secretions, the colour of the consistency, and when you've done, flush the suction tubing with sterile water at the bedside. And you should document how many times you've attempted suction as per our Princess Alexandra Hospital policy in the bedside tracheostomy care book. And here we can see it here. This should be in your bedside, and that's there for you to document every time that you suction or remove the inner cannula to clean it, or that you've checked the cuff pressure itself. Of course, you should always have this sign at the end of the patient's bed to alert people to know that the patient has a tracheostomy, particularly in an emergency. And to access this, you can download it from tracheostomy.org.uk, or you can get them from the critical care outreach team. So let's have a think about the complications of suctioning. Well, number one is hypoxia, and which could lead on to cardiac arrhythmias and hypotension. The alveolar lung units may collapse, known as atelectasis, and this puts the patient at increased risk of infection. As I mentioned, we can cause trauma to the tracheal mucosa, and it can be painful for some patients and may induce some bronchospasm in others. The patient may vomit from the repeated coughing. We should always use caution in people that have severe bronchospasm, as in acute asthma, or if they've had recent upper GI or pulmonary surgery, and clotting disorders or any other risk of bleeding. You need to be cautious as well, and you should always seek for more experienced help if your patient has any of these. Of course, I've mentioned removing the inner cannula and inspecting it and putting it back in again after you've suctioned, but there is a procedure to it, and here it is. Tell the patient what you're doing and let them know, and position them upright or in a position that's as comfortable for them as possible. And again, this can be governed by their level of illness. Wash hands, put the appropriate PPE on, and because this might elicit a cough in your COVID positive patient, you need a long sleeve gown, some gloves, an FFP3 mask, and some goggles or a visor. It's important to splint the tracheostomy flange with one hand and grasp the inner tube with the other, so that you don't pull the whole tube out while you're only attempting to remove the inner tube. Gently but firmly remove the inner tube. It will be locked, so you may encounter some resistance initially. Some tubes will need to be twisted to be unlocked, but we don't commonly use those tubes at Princess Alexandra Hospital. And then you want to replace that immediately with an inner tube that's clean. So have that ready. Here's the steps here. There's 2 steps for removal and 2 steps for the insertion. There's a ring pull on the Portex tracheostomy tubes that we use at the Trust. Important to grasp that with your other hand holding the tube against the flange and removing the inner cannula gently. Don't be worried too much if it makes the patient cough. A bit of tube irritation can make some people cough. Reinserting a clean one, you splint the flange again and hold as shown at the end there, and just gently insert the tube back into the tracheostomy and set it in until the connector clicks into place, and you'll hear a snapping sound when that happens. So we haven't quite finished changing the inner cannula just yet. What we want to do is clean the soiled inner tube by running it under tap water using a brush. Shake off the excess water and allow it to dry in a container that should be dry. Don't soak them because still water in hospitals with a bit of mucus in it always attracts microorganisms. Dispose of any waste that you've used, your gloves and your apron, and document. So the minimum standard is at least once per shift. But on the wards, we normally do this every time we suction a patient, and it can be up to 2 hourly for at-risk patients. And they're the ones with lots of thick, tenacious secretions. So on to cleaning the tracheostomy stoma itself, doing the dressing and changing in the ties. We can see here that this patient has a tracheostomy in situ with a stoma dressing that looks nice and clean underneath the flange, and it's tied in with a Velcro tie. And the eagle eye amongst you will notice it's a 9.5mm internal diameter tube, and the flange is upside down. So for safety reasons, changing the ties and doing the dressing is a 2-person technique. 1 person to hold the tube and the other to visually assess for redness, swelling, purulence, any signs of infection, and if you see one, please do take a swab. But also how much drainage there is around the stoma itself, if there's any secretions that have pooled and are leaking around it. This can be a problem with humidification. But if the skin does look irritated, then barrier cream can be applied. So don't forget, it's a 2-person technique. Please do tell the patient what you're doing and why, and that there will be 2 of you. It's an aseptic technique because it's a dressing in hospital, so please use a dressing pack and Normasol. Wash your hands beforehand and put on your appropriate PPE. So in your COVID positive patients, because this procedure may elicit a cough, that's deemed an aerosol generating procedure. So you should wear your full length gown, your gloves, your FFP respirator if it's been fitted, and a visor or goggle to protect your eyes. And don't forget, it's a 2-person technique. So remove the ties and the soiled dressing while the other person holds the tracheostomy, and proceed to clean and dry with the saline and gauze. Now, when you're putting the ties back on, it's easy to make them too tight, which can be uncomfortable for the patient. So one technique in which to ensure it's secure, it's not too loose or it's not too tight, is if you're able to slip your index finger nice and snugly underneath the ties. If you can't, then it's too tight. So weaning from the tube is a process used to describe the eventual removal of the tracheostomy tube, and we use 4 steps generally at first. So first we'll try to deflate the cuff in either fenestrated or non-fenestrated tubes. And then, if all goes well, we'll attach a speaking valve, but you should only put these on fenestrated tubes to allow enough airflow past and through the tracheostomy itself out to the mouth. And then, all being well, we'll use a special cap called a decannulation cap, which is really just a plug that we put in the opening of the tracheostomy, but only for fenestrated tubes. So in effect, we're blocking off the tracheostomy to see how well the person breathes past the tube and through the mouth. And then we will remove the tube, all being well, making sure that there's a good stoma seal to facilitate an effective cough. If the stoma is not sealed, then secretions can leak out of that hole, impairing wound healing. So these patients often have limited communication, and even when they have a fenestrated tube in and are able to speak, their voice will be very weak. So it's important to think about using non-verbal forms of communication like writing or use of letterboards. Texting on a phone might be helpful, or using an iPad or tablet for them to type out words or sentences. And once you've found the best way, it's always important to be consistent between staff and what the best method is. It's worth pointing out that many of these patients will have a residual weakness, so may not be able to write, and pointing to letters, although it might be time consuming for us, will facilitate better communication between them, us, and the rest of the team as well. It's important to advocate for the patient, so ask them what questions they have when the ward round comes along, as well as the questions that you have on their behalf. These patients can get enormously frustrated at their lack of communication or being able to communicate with us effectively, and anger might be a sign that we're not really getting it right. Patients feel quite vulnerable as well. They know they've got a fragile tube because we take so much care around it. So be prompt when the person asks for help. Procedures like suctioning can be painful, and any procedure offer the person some privacy and dignity, because they may be embarrassed with the procedures that you do with their tracheostomy tube specifically for them, may not be socially acceptable for them, for other people to see. And also be aware that we see a lot of things in hospital that become routine to us, and it's not just another task that for the patient that we do. Often it's new to them, so it's always helpful for them that you explain what you're doing and why. So I mentioned speaking valves before. These function as a one-way valve, so they're an attachment that's set at the end of the tracheostomy, and it allows the person to breathe in air through the tube itself. But once the person breathes out, it closes off, forcing the air through the upper airways, through the voice box, and out through the mouth. And that allows them a stronger voice, if you like. So you need to sit them upright when you're doing this first. Ask the patient to cough to clear their tracheostomy, or you may need to suction through it. Make sure the inner cannula is fenestrated and that the cup is deflated. Put the speaking valve over the outer hub of the tracheostomy tube and continue with their oxygen if they're on it. You need to frequently assess their vital signs, because they do increase the work of breathing, and the patient may become fatigued quite quickly. So stay with them in the initial phase and reassess them. And often we'll do trials of 1 hour and increase that gradually as they get stronger. And here's an example of the speaking valves that we use. They all look a little bit different to each other, but they all effectively do the same thing. Now, when we're thinking of taking the tube out itself, we put a cap on the end of it that blocks the tube itself, called a decannulation cap. So we use it in the last bit of the weaning process. It blocks all airflow via the tracheostomy tube, so the patient can't breathe in and out of the tube. They are breathing through their mouth and their nose, essentially. And if they're able to do that, we know that they can do without their tube. So make sure that if you're using a cuffed tube, that the cuff is completely deflated. Otherwise, they will not be able to shift any air past the cuff if they're breathing through their mouth. Again, just like the speaking valve, we should be assessing them closely during this process for signs of respiratory distress. And we may also have to gradually increase the length of time at which they can tolerate it. Before you put the cap on, just place your finger over the end of the tracheostomy tube first before you put the cap on, just to see as a guide as to how well they will tolerate being capped off. And here's an example of a tracheostomy tube that's got a decannulation cap on. They're usually red. This is quite a small tube at size 5, and also you'll see that it's a non-cuffed tube. They come in different types, but as I said, again, usually red. Well, that's about it for part 2 of the Tracheostomy Bite Size, Suctioning, Communication and Weaning. Don't forget to head over to the National Tracheostomy Safety Project at tracheostomy.org.uk. There's lots of interesting educational material there for you, including a really good e-learning package. There's also a place for you to download the bedheads and the emergency algorithms that we'll be talking about in part 3. And if you want to watch a cuff deflation, or someone have their speaking valve applied, or be suctioned themselves, then go over to their videos. That will take you to a link to their YouTube site that we also follow on here.